Hi there, my name's Will Niven. I'm a consultant in emergency medicine at the Royal Surrey Hospital, and I'm going to chat to you today about how to evaluate a diagnostic test. Whilst the background and introduction to a paper gives a good idea of why a particular study has been done, ultimately the strength of a paper rests upon the quality of its methodology. Not unlike studies of a therapy, we're interested in whether a Peacock-style question has been asked. So, for instance, in adult patients presenting to an emergency department, is high sensitivity troponin I superior to a standard troponin I in the diagnosis of a major adverse cardiac event in the time period of 30 days? You might want to drill down a little bit more into the population, so you might ask questions about what the setting was. Was it in a district general hospital, a major trauma centre, a rural clinic? How much did the setting mirror your own setting? What was the sample size? Was there a calculation used to calculate it? Was it an estimate, or was it based on a pure thumbsuck? What were the inclusion and exclusion criteria? Obviously, the more exclusion criteria you have, the less generalizable the findings. How were patients recruited? How many were approached? Were they approached consecutively, or were they found from a list of patients on a database? And ultimately, was that sample size represented? In other words, were those recruited representative of the population of interest? When it comes to the control, you would ask yourself, what is the gold standard? And a gold standard is normally a single accurate test, for example, an angiogram for acute coronary syndrome, or a CTPA for PE, and in the context of a DVT, it would be a venogram. Unfortunately, the gold standard isn't always possible or actually practical, so not every single patient that comes with chest pain necessarily gets an angiogram. Not every patient that has a DVT is necessarily going to get a venogram. So what often happens is that we develop a reference standard, which is a combination of tests or a procedure that is the best available method of deciding if a patient does or does not have a condition. So an example would be Doppler ultrasound for DVT, or the fourth universal definition for myocardial infarction. Now, if you're studying a new test, then ideally every patient should get the gold standard and the new test. If you compare a new test to a test that isn't the gold standard, then you may get an inflated picture of how good the new test is. And the next issue is related, and that is the situation in which only some of the patients get the test of interest. This can then result in what's known as workup or verification bias. So, say for example, you wanted to see whether X-ray was good at picking up fractures, but you decided to only X-ray those patients who had wrist swelling. In this scenario, it's quite likely that you will pick up a lot of fractures, but you could be missing a few patients who had a fracture but no wrist swelling. And the end result is that you end up overestimating how good your X-ray is at picking up fractures, because you have a sample of patients in which the likelihood of a fracture was high from the get-go. The second form of bias is known as incorporation bias. And a really good example of this is troponin. So troponin is used to diagnose MI, but it's also part of the reference standard. Therefore, you're more likely to diagnose a patient with myocardial infarction in the presence of a raised troponin, even though we know that troponin can be raised in cases where there is in fact no MI. The next question that you might want to ask yourself was the test interpretation blinded? Was the person interpreting the diagnostic test blinded to the reference standard? Because if the person that's interpreting the test was aware of the outcome, then that could affect interpretation. So if the coronary angiogram showed stenosis or a clot, then it might mean that they look at an ECG differently and start looking for signs of ischemia. And the last concept, which I think is important to understand, is that of inter-observer error. So are the results the same when measured by different clinicians? And we know that in a lot of situations there is subjectivity in the way that we interpret tests. But obviously, the more clinicians agree on a measurement, the more reliable the test is. Numbers with cutoffs are relatively straightforward, whereas pictures, for example X-rays, are a little bit more difficult. And the way we measure this is with a test or statistical test called kappa, and that measures agreement, where 1 is perfect agreement and 0 is no agreement at all. Now, when we move on to onto the statistics involved in diagnostic tests, there are really 6 important concepts to understand. There are more, but these are the core. And they are namely sensitivity, specificity, positive and negative predictive value, positive and negative likelihood ratios, and ROC curves. These terms can end up becoming quite confusing quite quickly. So what we're going to do is use a test, a pretend test called the rainy day test. And what I would like you to do is imagine that we now have a new and pretty decent rain predicting test. And imagine that over 100 days we had 50 rainy days and 50 clear days. Now, if we look at sensitivity, what we're really interested in are the true positives. So that's the case in which rain is present and the rain test is positive, divided by what's known as the false negatives. In other words, those times when the test said that it wasn't going to rain, when in fact it did. And what we do is we divide the true positives by the true positives plus the false negatives. And in that scenario, we have 45 divided by 45 plus 5, and we times that by 100 and we get 90%. So sensitivity is otherwise known as the pickup rate. Another way of thinking about sensitivity is the proportion of patients with a disease who have a positive test. The value of sensitivity is in ruling diseases out. So a sensitive test that is negative is good at ruling the disease out, or snout, as it is sometimes referred to. Specificity, on the other hand, is the true negatives divided by the true negatives plus the false positives. The false positives being those times when the rain test was positive, but in fact it didn't rain. And what we do is we divide, in this case, 40 divided by 40 plus 10, and we get times it by 100, and we get a statistic or a percentage of 80%. A specific test is therefore the proportion of patients without the disease that have been correctly identified by the test. And it's important if you're ruling a disease in. So a specific test that is positive is good at ruling a disease in spin. So the positive predictive value is basically the true positives, in this case 45. So the rain test said it was going to rain, and in fact it did, divided by the total number of times that the test said it was going to rain. In other words, the true positives plus the false positives. And if we tally everything up and times it by 100, we get a statistic of 82%. So the negative predictive value is the true negatives. In other words, the times that the rain test said it was going to be negative and it didn't rain, divided by the total number of times that the rain test was negative. So it includes the false negatives. In other words, the time that it did rain, but the test said that it wouldn't. And we tally that up and times it by 100, and we get a figure in this case of 89%. A lot is often made of the fact that sensitivity and specificity don't change irrespective of the prevalence, whereas positive and negative predictive value do. So let's do this with an example. Say we now had a different time of the year, such as winter, in which it rained out 80 days out of 100. Prevalence is 80%. So if we want to do our sensitivity, what we've got to do is calculate the number of true positives, so 72 days, and divide that by the true positives plus the false negatives, which in this case is 8, and we get a figure of 90%. If we want to calculate our specificity, we've got to take our true negatives, which in this case is 16, and divide that by the true negatives plus the false positives, and we get 16 divided by 16 plus 4, so it's 80%. So as you can see, sensitivity and specificity has stayed the same. But now let's take a look at what's happened to our negative predictive value. So at a prevalence of 80 out of 100, so a high prevalence, we've now got 16 true negatives divided by 16 plus 8 false negatives. And we've now dropped our negative predictive value to 67%. whereas our positive predictive value, conversely, has gone from 72 true positives divided by 72 true positives plus 4 false positives, and our positive predictive value is now 95%, so it's gone up. If we were now to look at a different scenario where it's summer and it's only raining 20 out of 100 days, let's see what that does with our numbers now. So bear in mind the prevalence is now 20%, so 20 rainy days out of 100. And we now start looking at our sensitivity. 18 true positives divided by 18 true positives plus 2 false negatives. And that gives us 90%. If we're looking at our specificity, we've got our 64 true negatives divided by 64 true negatives and 16 false positives. And that gives us 80%. Our negative predictive value has now skyrocketed because of the low prevalence, and it's now 64 divided by 64 plus 2, so that's giving us 97% negative predictive value, and our positive predictive value has cratered. So we're now sitting at 18 divided by 18 plus 16, and that gives us the fairly lowly figure of 53%. The next concept I'd like to talk about is the likelihood ratio, of which there's a positive and a negative likelihood ratio. The important things to appreciate are that it's the probability of a given test being seen in an individual with the disease relative to it being seen in an unaffected individual. And crucially, it can be applied to individual patients. It gives us a degree of the usefulness of the test in helping us to make a diagnosis. And it needs to have, in order to be most effective, you need to use pretest probability. And then with the use of a nomogram, you can come up with a post-test probability after you've applied the test. So in terms of the statistics behind it, the likelihood ratio of a positive test is sensitivity divided by 1 minus specificity. And the likelihood ratio of a negative test is the inverse of that. So it's 1 minus sensitivity divided by specificity. Let's return to our rainy day test again. So you're wondering if you should take out your umbrella today, and as you're now a statistical whiz, you decide that you're going to use your likelihood ratio test knowledge. So you calculate the likelihood ratio of a positive test or of a negative test, and as we know, likelihood ratios of a positive test is sensitivity divided by 1 minus specificity. We get a likelihood ratio of a positive test of 4.5. And then in terms of the likelihood ratio of a negative test, we go 1 minus sensitivity, so 1 minus 0.9 divided by the specificity of 0.8, and that gives us a figure of 0.13. As I mentioned previously, you need to actually have an idea of what the pretest probability is. So let's say that today is a bit grey and cloudy, and we think that it might be more likely to rain. We say the pretest probability is, for example, 60%. We then go to our nomogram. This is our nomogram. And if we said that our pretest probability was around 60% and the likelihood ratio of a positive test was 4.5, if our test was positive for the rainy day test, then we could say there was about an 82% likelihood that it was going to rain. There was about 82% chance of it going to rain. If the rainy day test said alternatively that it was not going to rain, and we knew it was 0.13, and we drew a line between those 2 points, it would end up at around 16%. So what does that tell us? It tells us that this test is, something that's pretty reliable, and depending on whether it's positive or negative, irrespective of your pretest probability, it's pretty good at telling you whether or not it's going to rain. In practical terms, if we were to look at negative likelihood ratios, if you've got a negative likelihood ratio that's less than 0.1, that effectively rules the disease out. If you've got a likelihood ratio of a positive test greater than 10, that effectively rules the diagnosis in. And all these numbers between 1 and 0.1 give you a fair idea of where your test sits, depending on where it scores. So obviously if it's 0.1 to 0.2, it markedly decreases the likelihood of the disease. If it's 0.2 to 0.5, it sort of moderately decreases the likelihood. 0.5 to 1, it hasn't got much significance at all, and if it's 1, it has absolutely no effect whatsoever. And then moving in the opposite direction over there, 1 to 2, little clinical significance, 2 to 5, moderate increase in the likelihood of disease, and then 5 to 10, marked increase in the likelihood of disease. And again, you can see over here that if your pretest probability is high, and you've got a likelihood ratio of 5 to 10, then perhaps you might take your chances and say, I think this person's got the diagnosis under question. Equally, if the pretest probability was low, and they've got a score of, on the likelihood ratio of a negative test is 0.1 to 0.2, then you might again say, I don't think that they've actually got the disease. The final concept to talk about is receiver operating characteristic curves, or ROC curves. And they're basically a graphical representation of the relationship between false positives and false negative rates at each cutoff value for continuous data. And what you would do is you would plot the sensitivity on the y-axis, and then you would plot the 1 minus specificity, or your false positive rate, on the x-axis. And a good test is one that's got the greatest area under the curve. So an area of 1 up here represents the perfect test, and an area of 0.5, so this kind of line over here, would represent a worthless test. And these curves are used to decide where to make the cutoff between a positive and a negative result. A good test has a small number of false positives and false negatives, and if 2 tests are plotted on the same ROC curve, the test that lies above the other one is the superior test. So in this case, the yellow test is superior to the black test. And going back to our analogy, imagine the way that our test diagnosed rainy days was by looking at the percentage of the UK covered in cloud. And if we used 30% cloud cover as a cutoff, then our test would be about 0.4 or 40% sensitive for picking up rain, but we'd still have a 10% chance of saying it was going to rain when in fact it wasn't. If we used 100% cloud cover as a cutoff, then our test would be 100% sensitive for picking up rain, but there would still be a small chance of saying it was going to rain or 40% chance of saying it was going to rain when in fact it wasn't. So just because you've got a large degree of cloud cover doesn't necessarily mean that it's going to rain. If we were looking at the sweet spot of 80% over here as the cutoff, then our test would be 0.9 or 90% sensitive for picking up rain, and we would have a 30% chance of saying it was going to rain when in fact it wasn't. So hopefully that kind of elucidates or explains how ROC curves work. So in summary, I think it's important to approach diagnostic papers systematically and have a good look at the methodology when you're reading them. Check if a new test has been compared to the gold standard, and if they haven't used a gold standard and have used a reference standard, was that reasonable under the circumstances? Look out for verification and incorporation bias. Make sure that you have a good understanding of the main statistical terms that are used in diagnostic papers. And finally, get into the habit of reading lots of papers and practicing critical appraisal. Thanks very much.